Hi everyone, it's me again. We're back in the locker room and going to get to the whiteboard in a second. If you've been following sort of our sequence and what we've been addressing around COVID-19, a lot of it has dealt with this idea that in addition to trying to mitigate a viral load, we should also be trying to mitigate the cytokine load, as it appears that the cytokines, the pro-inflammatory cytokines, or as we renamed them as a group, threogens, are actually what precipitates our death when they escalate into what's called a cytokine storm. And along the way, we've been talking about the strategies for mitigating the viral load, which at this point have been to get a vaccine, which is months, maybe potentially years away, and we don't really know about the efficacy, and we don't know what happens as the virus itself mutates and changes its presentation, how well a vaccine will work year to year or season to season. We've talked about the antiviral medications, and there is one out there that seems to show some promise and is being trialed, I believe in phase 2 right now. And we've talked about this other idea of distancing, physical distancing and isolation that mitigates the spread of the virus and therefore mitigates the viral load. But these strategies don't have an immediate, clear endpoint that we can do something about. And we've talked about in a session called Plan B that we may, want to look at some other strategies other than just mitigating the viral load, and as I said before, primarily in terms of mitigating the cytokine load, but also some strategies to develop some herd immunity so that we can actually get out of this situation, which is causing a lot of social and financial trauma, and therefore psychological trauma as well. So that's kind of been the background. We did touch briefly, particularly in a talk called "In the Weeds," on how COVID-19 sort of attacks our body and hijacks our body's systems, our cellular systems, our cellular metabolism and reproduction systems to replicate itself and become obviously much more potent and virulent once it has numbers in your body, and also then it can be spread and propagate and perpetuate itself. In that discussion, we got into the specific receptor that the COVID-19 virus attaches to get into the cells, and kind of the sequelae of that. So it's really that route that I want to go a little further down today and explore that, and explore some of the kind of side syndromes that we're seeing with COVID-19 that are not actually just the cytokine storm, but are kind of like the counter punch, right? If the knockout punch is the cytokine storm, the mechanism by which it hijacks our cells and the sequelae, it's a lot of the jabs that are setting up that knockout punch, and we haven't really talked a lot about mitigating those jabs, and perhaps by doing that, being able to also mitigate viral load and cytokine load. So that's what I want to get into today, is this other sideshow that's kind of going on, that's connected, but not exactly what we've talked in depth about before. So let's go up to the board here, and I'm going to start over here and just talk about, we know what happens in people with a lot of comorbidities and people who are older, that this primarily seems to present as an attack the pulmonary system or respiratory system, where they go into something called acute respiratory distress syndrome, which is a shock syndrome, which is mitigated or mediated, I should say, by a cytokine storm, and they can no longer oxygenate, and a lot of other chaos going on in the body at that time with leaky membranes and collateral damage to vital organ systems, multi-organ kind of failure, and eventually death. So that's kind of what we think about. But there's some other things going on, they appear to be going on with COVID-19. And that's this issue of, in younger adults, we're seeing stroke syndromes. So, what's that all about? Let's talk about that in a minute. And also then in children, we're seeing vasculitis and glossitis. Vasculitis meaning inflammation in the blood vessels, and glossitis is inflammation of the tongue. So, what's that all about, and how are these related? And we should also note that in post-mortem studies of people who have sort of died by what we think are the traditional processes of ARDS, the typical sort of COVID-19 death, they are seeing sort of micro clots or thrombi throughout their bodies that have formed. And we know in shock syndromes there's this thing called a coagulopathy that can occur. So let's just think back real quickly. If I'm running from the tiger and the tiger's going to bite me, I want my platelets and my coagulation factors to be really active so I don't bleed to death, and I can maintain the fight and the flight. So in these intense viral attacks, that same mechanism can get activated, and it can create a excuse me, a coagulopathy where we tend to clot up, and then sometimes it gets so extreme that we use up all of our coagulation factors, and then we're actually at risk for bleeding. So that's kind of known in shock syndromes, ARDS, septic shock, systemic inflammatory response syndrome, things like that. That can happen. But these kinds of things, and the type of thrombi that they're actually seeing after death in people who have passed away from COVID-19 and ARDS, aren't that classic shock syndrome coagulopathy. They're different, and so that's what we want to kind of dig into. So anyway, that kind of sets the table. Let's just turn over here and refresh our memory that the virus, its access ports are typically through the openings in our face, right? It can get in through our eyes, get in through our nose. It can get in as well through the mouth. We don't really feel like a lot of the stuff that comes through the mouth maybe actually can survive the entire digestive tract very well because of the acidity and all the enzymes in the digestive tract. But we do know that a fair number of COVID-19 patients do present with gastrointestinal symptoms. It can be nausea, vomiting, diarrhea, kind of a typical viral gastrointestinal attack, and maybe more so even in kids it might present in that way. So we do know that we have a tendency to lose the sense of smell and the sense of taste, and we can kind of talk about that in a second as the viral particles come into our system, and they tend to kind of initially really want to populate in the back of our throat towards our tonsils, where then eventually the viral particles, either through the blood or actually just through the respiratory tract, can get down into the lungs and really create havoc in our system. So we've talked about before that the virus, how it gains access to our cells and can then hijack our cells for replication, is through this angiotensin converting enzyme 2, which is a receptor on the surface of our cells. And we've represented this here before with this green area being the surface of our cell, we're the host, welcome, the host cell. And that the virus has these spike proteins or S proteins that it sticks into the receptor there, and then it can get into the cell and start its replication process. And then it has an exit strategy from the cells as well, but a lot of times the cell actually will die and open up and release these things, and then they get back into our bloodstream or attached to other cells and kind of disseminate the whole process. So these angiotensin converting enzyme, and we're talking about the number 2, are in many of our visceral structures, okay? We know that there's a load of them on our olfactory bulbs, which is where our sense of smell is. So, you know, if you get a big load of a virus on those receptors up, in kind of the back of our nasal passages, and an inflammatory response going there, you could see that might block getting a good smell through. And we also know our tongue is loaded with them. Of our oral tissues, our tongue has the most of these angiotensin converting enzyme 2 receptors. Now, to be honest, I'm not really sure why that is. I can't quite process that, but we don't need to go there. But obviously, if you get a viral load on those angiotensin converting enzyme 2 receptors, that you get an inflammatory reaction in the tongue, and that you wouldn't be able to taste very well. And then in kids, that looks like this, right? It looks like an inflamed tongue. Kids get a really pink kind of inflamed tongue, or glossitis, and it's probably related to getting virus attached to the angiotensin converting enzyme receptors of the tongue and an inflammatory response there. Okay, so let's talk a little bit more about the other organ systems that have a lot of angiotensin converting enzyme type 2 on them, and we've illustrated that here. Obviously the lungs do as well, the heart does as well, the kidneys do as well, our gonads do as well, maybe less so the liver and the spleen. But what's kind of really important in this is our blood vessels are full of these angiotensin converting enzyme 2 receptors, because angiotensin 2 has a very specific function for our blood vessels when we are under threat, okay? And as we talk about up here, we've talked about threat being sort of the rise or the attack of the threogens, the pro-inflammatory cytokines, but its cousin, angiotensin 2, is also involved in this attack. So why is that, and how does that work? Well, if we are running from the tiger, we're sweating profusely, right? Or if we're fighting the tiger, and maybe not so smart, but we might choose that route first and then start to run. And so we're going to sweat a lot, but if the tiger bites us, we may bleed a lot. So we need to do some things internally. Our body is anticipating perhaps some bad outcomes from this attack, and is going to do some things to protect us, to help with our survival. And one of those things is our body wants to keep our blood pressure up so that we will be able to perfuse necessary parts of our brain, not all of our brain, perfuse our heart, perfuse our lungs, and perfuse our muscles so that we can sustain the fight and flight. What ends up happening is the signal coming down to the brain that we're under threat, or it can even come from the periphery, like if you get bit, or from the periphery if you are getting a virus. It will stimulate this same response as if we were being attacked by a tiger, and it tells our kidney to produce renin, okay? So then renin goes through the circulation from the kidney to the liver, and in the liver we get the production of something called angiotensin, and then angiotensin 1 gets converted by angiotensin converting enzyme, and let's call that 1, to angiotensin 2. So angiotensin 2 causes our blood vessels to constrict. It helps maintain our blood pressure, but it also helps to shunt blood to the organs that most need it, such as our muscles, and shunts blood away from our organs that don't need it as much. And we've talked about how we don't need our prefrontal cortex that much in fight or flight, so we actually don't give it as much blood in fight or flight. We also don't give much blood to our stomach. Now, as you know, we start running and creating a different environment in our musculature, those blood vessels stay dilated and perfused. So this is something that more gets very specific fascia and very specific organs or visceral tissues to decrease their blood flow when they're not needed in fight or flight. So it has a really important role in doing that. And let's just kind of complete the renin, angiotensin, aldosterone, vasopressin system just before we move on. So the other thing that happens is that through this kind of same system and pathway, we get a signal to our adrenal gland, not only to produce adrenaline and cortisol, but to produce this aldosterone. Aldosterone tells our kidneys to hold on to salt or sodium, which is a good thing because we're sweating a lot. But also when we hold on to sodium, we tend to then be better able to hold on to water. And that's why if you eat a salty meal, you might feel a little puffy afterwards. And then there's another hormone that comes out called vasopressin, and that actually does not come out of the kidney or the adrenal gland, but it actually comes out of the pituitary. But it goes down and tells the kidney to hold on to water. It's an antidiuretic hormone. And it's really interesting that vasopressin and oxytocin, the love hormone, they look an awful lot alike, and they come from the same kind of structures up in the hypothalamus down through the pituitary to come out. But in threat, in fight or flight, we're pushing out vasopressin to hopefully maintain our blood volume and our blood pressure. But when we're out of threat and we're in a safety mode, we're pushing out oxytocin, the love hormone, and there's probably a little switch in there that just slightly deviates the production of these hormones, going back and forth between the two and prioritizing which one is needed based on threat or safety. So that's just really cool and kind of a digression from what I'm talking about. So now the other thing about angiotensin 2 though, it's highly inflammatory. And remember, in our minds we go, inflammation is not good. Well, inflammation is good in an acute attack situation, whether it's from a bacteria or a virus or a lion, tiger, or bear, or another person. And particularly, it was really good prior to antibiotics. So 200,000 years ago, we needed that aggressive inflammatory response to bring in all these immune cells, monocytes, macrophages, lymphocytes, whatever we need to go in and kill the bacteria, the parasite, the virus, clean up the dead tissue, all that kind of stuff. So our inflammatory response is a good response. It is protective to us under acute attack, but under chronic conditions, it's not so good, and sometimes it gets out of whack. So, and we know the cytokine storm is one of those out of whack situations that puts us, into freeze-frame collapse physiology as another protective response, but it is inching awfully close to death. So that's scary. So angiotensin 2 is highly inflammatory. So not only is it vasoconstrictive, it's highly inflammatory. Well, let's talk about exactly why that can become a problem in the situation we're talking about with COVID-19. So if this represents a blood vessel running this way, and we've got a ton of angiotensin coming out under threat, and so the blood vessel's going to constrict, and it wouldn't necessarily be just that focal, but that's just a cartoon to demonstrate vasoconstriction. It gets narrower here with angiotensin 2 causing vasoconstriction to support our blood pressure, right? Well, the inflammatory aspect of angiotensin 2 bringing in a lot of inflammation into that blood vessel can damage the thin skin inside the blood vessel. So the endothelial layer inside the blood vessel can get damaged by this inflammatory response, okay? So just think about if you cut your skin. What happens there? You get a clot, right? You get a scab kind of thing forming. Well, the same thing happens on the skin inside the blood vessel, this thin endothelial layer that's full of angiotensin receptors. And so you get damage there. And so the platelets come in to heal the damage. Our coagulation factors help to kind of clot that thing up. You get layering of something called fibrin, or kind of a proteinaceous clot, and then your blood fats can get caught up in there. Cholesterol can get into that little scab that's forming. And you can even get a lot of cellular debris, right? White cells going in and getting stuck, and red cells being in there. And so you create essentially a scab on the inside of the vessels. So this is called a thrombus, right? So if this thrombus gets too big and the blood vessel's vasoconstricted, all of a sudden you've got this issue where there's no blood flow coming through, okay? So what is that going to look like? Well, it's going to look like, tiny strokes perhaps in the brain, okay? Young adult syndrome here. But you can also see these little clots occurring in little organs, or maybe even down in the smaller vessels in your fingers and toes, which we also see with COVID-19 infections. So, and people seem to be relatively perplexed by, why this would be, and it's so unique to COVID-19 and the syndrome we're seeing. Well, the story gets worse because the angiotensin converting enzyme 2 here is responsible for cleaving this protein, chopping this angiotensin 2 protein up, right, and deactivating it. It actually takes a vasoconstricting, high blood pressure, high inflammation chemical and chops it up into different angiotensins that actually are anti-inflammatory and dilate the blood vessels. So our threat response is throwing out this angiotensin 2, and yet all of our receptors for converting it to a less toxic form, actually a healthy form of angiotensin, are being consumed by the virus itself. So now we have this block of cleaving up this stuff, and so now we're going to get a lot more A2 just circulating in our bodies, and this whole thing starts to get out of whack. Okay, so what we also need to attend to in this whole equation is this counterpunch guy. He's not the big punch guy. The big punch guy is probably the cytokine load. The initiation of it all is the viral load, but this angiotensin load is a significant factor in this entire illness and disease process. So one of the strategies that you could use is using our medications that are angiotensin converting enzyme inhibitors that prevent the formation of this angiotensin 2, or we have angiotensin receptor blockers that also block formation of angiotensin 2. There's been, discussion about that, and there's always this concern that if you block the formation of angiotensin 2, well, could you perhaps leave more angiotensin converting enzyme type 2 receptors open for the virus to get on and actually then increase the viral load on the body? And so giving those when, again, viral load is the instigator of this threat, that seems a little bit dicey, okay? So is there anything else we could potentially do? And so this is where this gets very theoretical. It's not, trialed or anything like that. But the argument would be that if you infused, and let me add one thing first, is not all angiotensin converting enzyme sits on a cell as a receptor on the surface of a cell. We do have free-floating angiotensin converting enzyme 2 in our blood, okay? So with that caveat, if we gave the human recombinant angiotensin converting enzyme 2 to patients in the fight or flight phase, probably later fight or flight fever and glucose fuel phase, but in that phase, and filled up the blood with angiotensin converting enzyme 2, would, and this is kind of another cartoon to illustrate what might happen, is that instead of these viral particles going and sitting on the angiotensin converting enzyme 2 receptors on the endothelium, they would be attached in the blood to the circulating and our own angiotensin converting enzyme 2 that's circulating, but also this infused sort of human recombinant version of it. So now if they get attached to this first, they won't attach to the cells, and you've just mitigated viral replication. Now you could say, oh my God, if we do that and all of the virus is held in the blood, we'll have this, fulminant sort of almost like a septic syndrome and worse vasculitis. But I don't think so. That viral circulation is already occurring, right? So we're not necessarily making the number of viral particles in the blood higher by doing this. We are just attaching the virus to angiotensin converting enzyme, and we don't know, maybe in that form the virus is not particularly virulent. I mean, its destruction is done by getting into the cell, so if it never gets in the cell, it may not create a more intense inflammatory response just based on dropping the viral load. It may be less, and perhaps it's easier even for our own immune system to chop up the virus once it's been anchored to an angiotensin converting enzyme 2 that's circulating in the blood. We don't know, but this is a really interesting strategy of giving the human recombinant angiotensin converting enzyme 2, because not only does it potentially mitigate the viral load, particularly the intracellular viral load, and hamper the replication of the virus, but it also mitigates the counterpunch, right? And we've talked a lot about strategies to mitigate the cytokine load, and I'm going to bring up one more later, but if we can get on top of this earlier with something like the infusion of, and let's put it up here on the board real quick. So we're going to call it HRACE2, the recombinant form, the man-made form of angiotensin converting enzyme 2. We might make a major dent in the sequelae, the morbidity and mortality of COVID-19, and not only in older adults with lots of comorbidities, but perhaps this is an option for younger adults with this syndrome or children when we have a sense that they're inflicted. Now, let's go back to Kawasaki's disease here. So this we don't know that this is really the same as the previous described Kawasaki disease. So Kawasaki disease is felt to be an autoimmune disease, and so what they've used to mitigate that historically is IVIG, which is an immunoglobulin. But it might be worth considering the fact that, post-viral syndromes like a Guillain-Barré syndrome, more common in adults, or Kawasaki's presentation of vasculitis or inflamed blood vessels, and Guillain-Barré being inflamed nerves, have responded to IVIG in the past. And so it might even argue in our list of things that we could do for this, for COVID-19, that IVIG might have a role. But it's very important to recognize that IVIG, it does drop pro-inflammatory cytokines, but it also drops our T cell function. It drops our white blood cells' ability to attack infections. So you wouldn't want to use IVIG in the acute flight fever and glucose fuel stage of the battle. Where you might choose to use it is to mitigate this cytokine curve in somebody who has a lot of comorbidities, and perhaps monitoring that by monitoring IL-6 for its rise, okay? So when that starts to take off and people are starting to move out of fight, flight, fever, and glucose fuel stage into a more freeze and faint collapse kind of stage, it's the timing is everything. You got to know it's going to probably be a few days out, but depending on their comorbidities, that day may shift. So you've got to have a point of care test to monitor where you're at. If you don't have a point of care test to monitor where you're at, you're literally flying a plane without the altimeter, right? So, but once you see this curve start ramping up, and a relatively high baseline level that's starting to trend upward, you want to get in and mitigate it right there. Well, IVIG might be another strategy for mitigating the curve. And we do know that IVIG does drop pro-inflammatory cytokines. Again, it also reduces our white blood cell function, our ability to use an immune strategy to fight the infection. But right here, we're talking about saving a life. So if the virus takes longer to dissipate out of the body, but we don't go over this threshold of crash and burn in terms of a pro-inflammatory cytokine level, people survive. They will shed the virus a little bit slower, but probably eventually be able to get rid of it. So, to summarize this one today, that was a little bit of a digression back into cytokine mitigation at the end, but with the idea of this being a little Kawasaki-like, IVIG does come to mind. You got to kind of think about it in the right timing. So this is later, as we're going from fight, flight, fever, and glucose for fuel phase, that you would, and we're going into freeze, faint, and collapse phase, that you would contemplate this strategy for mitigating the cytokine load. But we really wanted to today talk a little bit more about this idea of mitigating the viral load and this counterpunch process of the angiotensin load by giving the COVID virus plenty of receptors to sit on in the bloodstream with giving human recombinant angiotensin converting enzyme 2 so that it never actually gets to be able to attach to the angiotensin converting enzyme receptors on our cells, particularly the ones in the lungs, and that our body can basically simply attack this virus while it's still bloodborne and not in our tissues. The one argument that I can see coming up is if you say, well, it really isn't a blood kind of transported process early on. It's much more of this getting into our openings in our face, through our eyes, our nose, perhaps our mouth, and by that pathway getting down into our lungs. And I won't discount that, but at a certain level, it is bloodborne, particularly as it starts to replicate. And so it may not be able to, totally mitigate the initial phases, but by the time we discover we're COVID positive and perhaps, getting down that the fight, flight, fever phase, it would be getting into the blood, and we could, really do a nice job of mitigating both the angiotensin load and the viral load with this strategy. So I throw that out there. People need to contemplate it. People need to think about whether or not it's worth, putting it into a trial, because the outcome from this is not obviously clearly known, but given the battle we're in, it's reasonable to consider all options. On a whim, kind of, we threw out trials on hydroxychloroquine that were maybe even less well thought through than this concept right here. So I'll put that out there for consideration and see if something sticks. Thanks very much.